Next presentation, Dr. Masuma Parveen Mishu. She will present about association between untreated dental caries and children's height and weight.
Take your question out.
I'm Masuma Parveen Mishu. I have graduated from Dhaka Dental College Hospital. I have completed my MSc in Dental Public Health from University College London, and now doing my PhD. I'm in second year of my PhD in University College London under Commonwealth Scholarship. Today, the topic of my presentation is association between untreated dental caries and children's height and weight. We know dental decay is one of the most common childhood diseases which affects 60 to 90% children globally, and most of the decay remains untreated, especially in the developing countries, is the report of WHO. This is a very common picture we see in everyday practice. So a common question comes to our mind, whether there is any association between these untreated dental caries and the height and weight of children. Yes, several studies has been done on this topic, but they cannot conclude a single answer. There are different types of association. Here, I am showing a recent systematic review, which shows mainly three types of association. There is no association between dental caries and child growth. Secondly, there is a positive association, that is, it is associated with higher weight, obesity of the children. And thirdly, there is an inverse relationship between these two. That is, dental caries is mostly associated with undergrowth, under height and weight of the children. Most of the studies from the developing countries shows this third type of association, that's an inverse association. That is, dental caries experience is associated with poor child growth and low weight gain. And further evidence comes from the weight gain studies, which shows after doing the dental treatment, children get more weight, and also they improve their quality of life in a significant number, like they increase their eating performance, sleeping, and overall quality of life. From the report of two recent systematic review in randomized control trials shows that after doing dental treatment, the child improve appetite and also improve their sleeping, which have impact on their weight gain. So, three possible causes are underlying this, which have been suggested, that if a child have dental caries, it reduces food intake due to pain and discomfort. Secondly, poor quality of life affecting child's growth, and one impact may be through reduced sleep. And thirdly, dental infection may result in cytokine release, which might have impact on growth. Actually, this paper was published in British Dental Journal, and this Professor Obrisham is one of my supervisors, and through my PhD, I am trying to answer these first two steps. What was the aim of my study? We know there is not much dental epidemiological studies has been done in Bangladesh, so the aim of my study was to examine the association between dental caries and age-adjusted height and weight among 6 to 12-year-old children in Bangladesh. This survey was conducted in 2007 in 9 randomly selected primary schools from different socially deprived areas. 4 schools was from slum urban, 2 suburban, and 3 rural sites were selected. And data collection included clinical dental examination, anthropometric measurement, that's measurement of their height and weight, and administration of a questionnaire to the children. And all the clinical dental examination and anthropometric measurement followed WHO guideline. So after entering all the data, cleaning the data, we did the statistical analysis by using Stata10 software. And after doing the descriptive analysis, we ran a series of linear regression model. Linear regression model is where we can add different confounders to our analysis so that we can exclude this factor to get a significant answer. So here, we have adjusted our models with sex, subsequently with area of residence, socioeconomic position, skipping meals, and finally tooth cleaning and visit to doctor. And lastly, logistic regression model. Firstly, we ran linear model, then logistic model, which where we have cut off the child as underweight and normal weight, and underweight was considered as weight for age Z-score less than -2 is WHO recommended, and adjustment it with the same confounders. So what was the result? Totally 1,699 children were included in the analysis, and overall 61% of children had caries experience, and mean TMFT was 1.39 in deciduous tooth, and most of the caries were untreated. Is the descriptive table. Firstly, if we show by age group, we have found that 60% of 6 to 8 years had dental caries, and 29% of them were underweight. And among 9 to 12 years old, 50% had dental caries, and 24% of them were underweight. This graph shows the distribution of caries and underweight by area of residence. Here we see that the children of slum urban areas are more likely to have dental caries and undergrowth rather than rural and suburban children. This table shows the result of chi-square test, which showed that the child have more underweight, percentage of more underweight in child among them who have dental caries in both age group. Next to table I'm going to present is the result of my linear regression analysis, and I'm presenting here only the final model that has been adjusted for all the variables. In this table, we are showing that the association between weight for age, Z-score, and number of decayed teeth. And this regression coefficient shows that with an increased number of decaying tooth, the chance of getting underweight is increasing, and which is statistically significant. We see the p-value, it shows the statistical significance of this result. And similarly, this table, here the outcome variable was height for age Z-score, and is also showing that the similar pattern of relationship. Lastly, the table I'm going to show is the logistic regression, the final model, and here is showing the odds ratio of association of underweight, that's the weight for age Z-score less than -2, with untreated caries adjusted for different variables. And this odds ratio, that's 1.61 and 1.47 in both age group, is statistically significant, which proves that with the child, those have at least one decayed tooth are more likely to be in underweight group. So finally, the results of the study demonstrated that weight for age and height for age was inversely associated with dental caries in this population. This relationship persisted even after adjustment of all the socioeconomic, behavioral, or eating variables. However, there are several limitations of this study, as it was a cross-sectional study, so we cannot say anything about the causality or reverse causality, or we can't use the word growth. Even though this study shows a significant association of untreated caries with underweight among Bangladeshi children, and this finding is highlighting an additional health burden in developing countries that caries could have an impact on children's general health and quality of life. After finishing, I would like to say something about further dental study, like in dental public health study. Oral health should get much priority in our health policy, and integrating oral and general health policies need to be considered to address a cluster of health problems. Thirdly, we can follow the common risk factor approach to address these problems, and it's my opinion that more dental epidemiological studies need to be done in this country. Particularly during my literature searching, when I was searching the DMFT level of this country, I was not getting much information to present my country, the condition of this population. So we can hope to run a dental health survey in Bangladesh. Like demographic and health survey of Bangladesh is running in every 4 years, so why shouldn't we try? Lastly, thank you very much and hope this type of smiley face to every children of Bangladesh. Thank you very much.
Thank you very much, Dr. Masuma Parveen Mishu, for your nice presentation. We are always thinking about the curative treatment or the curative side. But for prevention, we are still in the backward condition. Actually, we should look for the prevention. One thing, I asked our doctors, if we don't listen these presentations, this is for our knowledge. I feel really sorry sitting here to see the doctors are going outside and getting inside. And most probably, many doctors are loitering outside. We should give proper importance to this seminar. On the topic, one thing, this is a new data we have got. Actually, I congratulate Dr. Masuma Parveen for presenting this type of presentation. We don't think that one child having a bad tooth may have this hamper in his future height and weight, and for the mental development also. We don't think for that side. We are ready, always we try to hold the children or child and pull out their tooth. We don't think about the psychological aspect of that. So it is the time for thinking in that aspect. Our next presenter is Dr. M.D. Abu Said Ibn Harun. He will present about the mandibular bone changes in osteoporotic patient after treatment with zoledronic. Dr. M.D. Abu Said Ibn Harun.
I am Dr. M.D. Abu Said Ibn Harun from Chattogram International Dental College, and I'm graduate from Pioneer Dental College also. My topics is mandibular bony change in osteoporotic patient, especially postmenopausal osteoporotic patient, after treatment with zoledronic acid, that means bisphosphonates. Osteoporosis, which is literally means the porous of bone, a disease in which decrease the density and quality of bone are reduced, and bones become porous and fragile, and risk of fracture is gradually increased. The loss of bone occurs silently and progressively. Often there are no symptoms until the first fracture appears. This is the picture showing from American College of Rheumatology, shows the normal bone and osteoporotic bone. There are a lot of change in trabecules of bones. Osteoporosis is systemic skeletal disease, normal bones and osteoporosis bones. These graphs show the changes the bony quality within the age. Increasing of age decrease the bony quality of patient. These pictures show relationship of age and vertebra. In case of osteoporotic patients, in age 40, there are no caposis, 60 increase caposis, and 70 finally the patient become caposis. In case of the woman or male involving osteoporosis. This next picture shows in my slide, there are the relation between systemic osteoporosis and mandibular bones also. Global epidemic of osteoporosis, 1 in every 3 women, 1 in every 5 men suffers from osteoporosis. Among those who live to 90 years of old, 1/3 of the women and 1/6 of men will have sustained osteoporotic fracture. Hip fracture mortality at 1 year is approximating 25%. This picture shows as like as iceberg, osteoporosis is a silent killer. Now we can talk about the implant. Implant, we know very well. Implant is a bone-supported prosthesis. There are two prerequisite factors to successful implant: having no disease or condition that interferes with proper healing after implant surgery, and others factor having enough amount and density of jawbone to secure the implant. Now I talk to you about the systemic osteoporosis effect in dentistry. Reduce the bony mesh and density of alveolar bone. Those are the prerequisite factor for successful implant. Bony loss around the tooth or edentulous ridge, risk indicator for periodontal disease, accelerated alveolar bony resorption. Important concern during dental treatment in removable prosthodontics, when condition of residual ridge are important, bony regeneration technique and dental implants, when sufficient bone volume and mesh are important for success. From our research, we are about 1,500 postmenopausal osteoporotic patients included in our research. We saw there are mandibular cortical bones. In normal patient, C3, that means more porous in cortical bones, 1.39, whereas osteoporosis patient, 68.56%. And another point, alveolar bony resorption. In osteoporosis patient, generalized alveolar bony resorption in 91.21%, whereas normal patient, 48.61%. Mandibular bony mesh and pixel intensity. I only described the mandibular bony mesh. In normal patient, 104.5, standard deviation 14. In osteoporosis patient, low, 83.5, standard deviation 12.27. Widely used in agent, anti-resorptic, anabolic, drug-acting. FDA approval option, estrogen replacement, bisphosphonates, calcitonin, and parathyroid hormones. Today I discuss, and my research is related bisphosphonates, gold standard for the treatment of osteoporosis. Zoledronic acid, we use zoledronic acid 5 mg by intravenous infusion 1 year. In world perspective, zoledronic acid increasing. Mode of zoledronic acid, bisphosphonate, work by suppression or reducing bony resorption by osteoclast. They accomplish the effect directly by inhibiting the recruitment and function of osteoclast. On a molecular level, bisphosphonates bind to the surface of hydroxyapatite crystals within the bone. A cluster inhibits enzymes critical to the functioning of osteoclast. The chief enzyme targeted by a cluster is farnesyl pyrophosphate synthesis. These tables show in treated group mandibular bony mesh. In osteoporosis patients, 83.5, whereas treated group increasing up to 98 and resemble to normal. Conclusion, osteoporosis is a major public health issue associated with significant morbidity and mortality and health care cost. Dental surgeon can make early diagnosis. Low dose of zoledronic acid can improve the alveolar bony mesh rather than bisphosphonate related osteonecrosis of jaw. Bisphosphonate will be key role play in regenerative dentistry. This is the recent international article from me published in international journal. Thank you all.
So I call next presenter Dr. S.M. Zaki Azam. He will present a comparative study on fracture strength between ceramic polymer crowns and metal ceramic crowns. Dr. A.S.M. Zaki Azam.
The title is a comparative study on fracture strength between ceramic polymer crowns and metal ceramic crowns. With the presenter, Dr. A.S.M. Zaki Azam, working in the Department of Dentistry, Rajshah Medical Hospital. The aesthetic appearance of a crown as well as its functionality is extremely important. Metal ceramic crowns gained the popularity for natural appearance of porcelain, but its metal substructure does pose some limitations like lack of depth of translucency, metallic color hampering the aesthetic in marginal gingival area, and metallic allergy. On the other hand, ceramic polymer crowns provide superior aesthetic with easy reproduction of natural tooth color. Aesthetically present and durable crown is an expectation. In anterior teeth, ceramic polymer crowns are used alternative to metal ceramic crowns for the treatment of defective and discolored anterior teeth. Ceramic fracture is common, and the remake process is technically sensitive, which is a clinical problem. Therefore, this study was done to assess and compare the fracture strength between the ceramic polymer crowns and the metal ceramic crowns. The objective of this study was to find out the fracture strength of ceramic polymer crowns, metal ceramic crowns, and to compare between the two. It was an experimental in vitro study. This study was done in the Department of Posthodontic, Faculty of Dentistry, Bangabandhu Sheikh Mujib Medical University, Bangladesh. And the sample was ceramic polymer crowns and metal ceramic crowns. There's two groups. The group A consisted of 15 samples of ceramic polymer crowns, and group B was consisted of 15 samples of the metal ceramic crowns. Fracture strength. The operational definition of fracture strength is the strength of fracture based on the original dimension of the specimen. In this experiment, the fracture of crown was defined as being broken down a crown into pieces or part of it separated or falling out from its position. A resin maxillary central incisor analog was prepared with bar, a 1.5 mm uniform circumferential and 2 mm incisal edge reduction. A 6-degree taper angle and 1 mm shoulder was produced. The axogingival and axo-incisal line angles were rounded. The prepared tooth was cast in a nickel chromium alloy for the fabrication of metal die. The metal die was embedded in autopolymerizing polymethyl acrylic resin block. The block was then ground flat to ensure that each specimen was secured and correct alignment when the compressive load was applied. The incisal edge of the metal die was parallel with the horizontal plane. The ceramic was commercially used for the making of the ceramic polymer crown. It is from Shofu, and ceramic is containing 73% zirconium silicate with an inorganic polymer material. And the solid light and light cure machine was used for the curing of its ingredient. Ceramic polymer crown and metal ceramic crown are fabricated from the same metal die. Every effort was made to create clinically relevant, standardized, and uniform specimens. The figure showing the samples of group A, the ceramic polymer crowns, and samples of the group B, that is metal ceramic crowns. The thickness of the crown was measured with the metal gauge at the midpoint of the labial, lingual, mesial, distal, and mid-occlusal surfaces. And the constant figure pressure was produced during the cementation of the crown with the phosphate cement for 5 minutes. A universal testing machine was used for testing of the fracture strength. A 50 mm diameter rod with cross-sectional speed of 1 mm per minute was used to load the artificial crown with the center of the rod in contact with the incisional surface. The crown was secured with metal jig. The load was directed at the incisolingual line angle at 130 degrees to the long axis of the specimen. This position was produced to the occlusal forces directed against the maxillary central incisor. The crowns after loading the fracture and the crowns after loading the metal ceramic crowns. The compressive load was recorded for the specimen and subjected to the statistical analysis. The fracture strength of the ceramic polymer crowns was 889.80, was significantly higher than that of metal ceramic crowns, that was 707.70. The table comparison of the compressive load between the group A and group B. The data was expressed with mean and standard deviation. The figure in the parentheses was indicated the range. The statistical analysis was done by unpaired student t-test. And the test of significant was calculated with p-value less than 0.05, was accepted at the level of the significance. Here the bar diagram showing the distribution of the comparative load in Newton between the two study groups. This experimental study was done to find out and compare the fracture strength assessed by the universal testing machine of group A and group B. The methodology followed in the study allowed the data compressive load in Newton to be collected from the each samples. This in turn permitted the accurate analysis of the results